Obesity management. Essential questions and answers on obesity management. Welcome back to the Everything Surgery podcast, where today we'll be tackling the most common questions facing general surgery or bariatric surgery residents about obesity management. We'll cover everything from foundational concepts and medical management to surgical approaches, complications, and outcomes. Pause video when you hear the word answer to attempt answer. Let's get started. Basic concepts and definitions. Question: what is obesity? Answer: obesity is a chronic disease defined by an excess of body fat, typically marked by a BMI of 30 kilograms per meter to the power of 2 or greater. Question: how do you calculate BMI? Answer: BMI, or body mass index, is calculated using the formula weight in kilograms divided by height in meters squared. Question: can you break down the BMI classifications for us? Answer: absolutely. Underweight, BMI less than 18.5. Normal, BMI 18.5 to 24.9. Overweight, BMI 25 to 29.9. Class 1 obesity, BMI 30 to 34.9. Class 2 obesity, BMI 35 to 39.9. Class 3, morbid obesity, BMI 40 or above. Question: what is metabolic syndrome? Answer: metabolic syndrome is a cluster of conditions: abdominal obesity, hypertension, dyslipidemia, and insulin resistance, that together increase the risk of cardiovascular disease. Question: what's the most accurate way to measure body fat? Answer: the DEXA scan, or dual energy X-ray absorptiometry, is considered the gold standard. Question: what about the Edmonton obesity staging system? Answer: that's a 5-stage system that assesses the medical impact of obesity, ranging from 0, no risk factors, to 4, end-stage disease. Question: could you explain sarcopenic obesity? Answer: sarcopenic obesity refers to a combination of low muscle mass and high fat mass, a scenario commonly seen in the elderly. Medical management of obesity. Question: what are the first-line interventions? Answer: diet modification, regular exercise, and behavioral therapy form the cornerstone. Question: what's the ideal rate of weight loss? Answer: around 0.5 to 1 kilogram per week. Achieving 5 to 10% total weight loss can greatly improve metabolic health. Question: what are the common dietary strategies? Answer: these include low-calorie diets, 1200 to 1500 kcal day, low-carb options like ketogenic diets, Mediterranean diets, and intermittent fasting. Question: which weight loss medications are FDA approved? Answer: Orlistat, GLP-1 agonists such as semaglutide and liraglutide, phentermine topiramate, and bupropion naltrexone. Question: how does semaglutide function? Answer: it's a GLP-1 agonist that reduces appetite and slows gastric emptying. Question: what about Orlistat? Answer: Orlistat is a pancreatic lipase inhibitor that reduces fat absorption. Its most common side effect is steatorrhea. Question: when should pharmacotherapy be considered? Answer: for patients with a BMI 30, or BMI 27 if they have a related comorbidity. Question: what's the most effective non-surgical treatment? Answer: a combination of GLP-1 agonists with intensive lifestyle modifications. Bariatric surgery, indications and types. Question: what are the NIH criteria for bariatric surgery? Answer: surgery is indicated for BMI 40, or BMI 35 with an obesity-related comorbidity such as hypertension, diabetes, or sleep apnea. Question: which bariatric procedures are most common? Answer: the most popular are sleeve gastrectomy, Roux-en-Y gastric bypass, adjustable gastric banding, and biliopancreatic diversion. Question: which surgery is performed most frequently? Answer: sleeve gastrectomy, accounting for 50 to 60% of all cases. Question: can you explain the Roux-en-Y gastric bypass mechanism? Answer: it's both restrictive, via a small gastric pouch, and malabsorptive, by bypassing the duodenum. Question: how does sleeve gastrectomy work? Answer: it's primarily restrictive. About 80% of the stomach is removed, reducing ghrelin and thus appetite. Question: what about adjustable gastric banding? Answer: that's a purely restrictive procedure. An inflatable band creates a small pouch. Question: which offers the best long-term weight loss? Answer: biliopancreatic diversion with duodenal switch, BPDDS, provides the greatest loss, followed by Roux-en-Y, sleeve, and then banding. Question: and the best for GERD? Answer: Roux-en-Y gastric bypass, as sleeve gastrectomy can worsen reflux. Question. What is the typical percentage of excess weight loss at 1 year? Answer. Roux-en-Y, 60 to 70%. Sleeve, 50 to 60%. Banding, 40 to 50%. Question. Where does endoscopic sleeve gastroplasty fit in? Answer. It's less invasive, offering about 15 to 20% total weight loss, but less effective than surgery. Preoperative evaluation. Question. What tests are needed before bariatric surgery? Answer. EKG, chest X-ray, blood work, glucose, HbA1c, lipid panel, sleep study if obstructive sleep apnea is suspected, and a psychological evaluation. Question. Why the psych evaluation? Answer. To screen for eating disorders, depression, and to assess the patient's ability to comply with post-op requirements. Question. Is pre-op weight loss necessary? Answer. Some programs require a 5 to 10% reduction to decrease liver size, facilitating surgery. Question. Why is a large left liver lobe important? Answer. It increases technical difficulty, so preoperative shrinkage may be needed. Question. What's the most common comorbidity? Answer. Obstructive sleep apnea. Surgical techniques and anatomy. Question. What's the size of the gastric pouch in Roux-en-Y gastric bypass? Answer. About 15 to 30 milliliters. Question. How long is the Roux limb? Answer. Typically 75 to 150 centimeters. Longer limbs mean more malabsorption. Question. What are the main steps of a sleeve gastrectomy? Answer. Division of the greater curvature. Stapling along a bougie. 36 to 40 French in size. Question. What is a bougie, and what size is used? Answer. It's a sizing tube, usually 36 to 40 French for sleeve gastrectomy. Question. What is Peterson's hernia? Answer. An internal hernia behind the Roux limb mesentery, post-Roux-en-Y gastric bypass. Question. Most feared complication of sleeve gastrectomy? Answer. Staple line leak, seen in 1 to 2% of cases. Question. Most common complication after Roux-en-Y gastric bypass? Answer. Marginal ulcer, affecting 5 to 15% of patients. Question. What's dumping syndrome? Answer. Rapid gastric emptying that leads to nausea, sweating, and diarrhea, often after Roux-en-Y gastric bypass. Question. How do you treat dumping syndrome? Answer. Small, low-carb meals, acarbose, and octreotide in severe cases. Question. What is the leading cause of death after bariatric surgery? Answer. Pulmonary embolism. Postoperative management and complications. Question. Most common early complication? Answer. Nausea and vomiting, typically from edema or stricture. Question. Most common late complication? Answer. Weight regain, affecting 30 to 50% of patients at 5 years. Question. What causes abdominal pain post-Roux-en-Y gastric bypass? Answer. Most often a marginal ulcer. Always check for NSAIDs or H. pylori. Question. How is a marginal ulcer managed? Answer. With proton pump inhibitors, sucralfate, and avoidance of NSAIDs. Question. Most common surgical emergency after Roux-en-Y gastric bypass? Answer. Internal hernia, either at Peterson's or the jejunostomy. Question. Signs of internal hernia? Answer. Colicky pain and nausea, with often normal labs early. A CT may show a mesenteric swirl. Question. How do you manage a sleeve leak? Answer. Stenting, drainage, or sometimes reoperation. Question. What's the risk of GERD after sleeve gastrectomy? Answer. 15 to 30%. Some may eventually require conversion to Roux-en-Y gastric bypass. Question. Most common nutrient deficiency after Roux-en-Y gastric bypass? Answer. Iron, due to bypass of the duodenum. Question. Which vitamins need lifelong supplementation after Roux-en-Y gastric bypass? Answer. B12, iron, calcium, vitamin D, and thiamine. Question. What is Wernicke's encephalopathy? Answer. A. Thiamine. B1 deficiency resulting in confusion, ataxia, and nystagmus. It's a medical emergency. Question. What's the risk of alcohol use disorder after bariatric surgery? Answer. It increases, especially after Roux-en-Y gastric bypass due to altered alcohol metabolism. Question. Most common cause of obstruction post-Roux-en-Y gastric bypass? Answer. Stricture at the gastrojejunostomy. Question. How is an anastomotic stricture treated? Answer. With endoscopic balloon dilation. Question. What is the risk of gallstones after bariatric surgery? Answer. 30%. due to rapid weight loss. Question. Should cholecystectomy be performed prophylactically? Answer. Only if symptoms or gallstones are present before surgery. Question. How do you treat bile reflux after sleeve gastrectomy? Answer. Proton pump inhibitors. Surgical conversion to Roux-en-Y gastric bypass if needed. Question. What is the most common cause of death in the first 30 days post-op? Answer. Pulmonary embolism. Early ambulation and chemoprophylaxis are vital. Question. What is the recommended VTE prophylaxis? Answer. Low molecular weight heparin and sequential compression devices. Question. When is an upper GI series indicated post-op? Answer. If a leak is suspected. To look for extravasation of contrast. Metabolic effects and outcomes. Question. What is the remission rate of type 2 diabetes after Roux-en-Y gastric bypass? Answer. 60 to 80% at 1 year. Question. Why does Roux-en-Y gastric bypass improve diabetes? Answer. It's believed that bypassing the duodenum leads to an increase in GLP-1, contributing to improved glycemic control. Question. What predicts diabetes remission after surgery? Answer. A shorter duration of diabetes, less than 5 years, is most favorable. Question. Does bariatric surgery improve hypertension and sleep apnea? Answer. Yes. Hypertension remits in 50 to 70% of cases, and sleep apnea in up to 80%. Question. What's the impact on fertility? Answer. Fertility often improves, especially in patients with PCOS, but pregnancy should be avoided for 12 to 18 months after surgery. Revisional surgery and failures. Question. What's the most common reason for revisional surgery? Answer. Weight regain or complications like GERD or stricture. Question. Most common revisional procedure? Answer. Conversion from banding or sleeve to Roux-en-Y. Question. How risky is revisional surgery? Answer. Complication rates are higher, around 10 to 20%. Question. What is sleeve dilation? Answer. Stretching of the stomach after a sleeve, leading to weight regain. Question. How is weight regain after Roux-en-Y gastric bypass managed? Answer. Endoscopic suturing, pharmacotherapy, or distalization. Miscellaneous question. What is the role of robotic bariatric surgery? Answer. Outcomes are similar to laparoscopy, but costs are higher. Question. Is there an increased risk of suicide after bariatric surgery? Answer. Yes, which is why screening for depression is so important. Question. What is the ASMBS? Answer. The American Society for Metabolic and Bariatric Surgery. Question. What is the 30-day mortality rate for bariatric surgery? Answer. Between 0.1 and 0.3%, actually lower than that of gallbladder surgery. Thank you for joining us for this comprehensive Q&A. For more deep dives into surgical management topics, subscribe and stay tuned.